Hello, and welcome back to SPT with J and Z. I'm Zach Carson.
And I'm Josh Griffith.
And we're here to break down week 2 of our journey through the Grand Valley State University Doctorate of Physical Therapy program. So this week we went another full week, which was great. That first part of the year, school buzz is kind of over. So now we're going to be plugging along all the way until Thanksgiving, and it's going to be a long haul.
We'll make it.
But I think we'll be okay. A lot of people are finally getting into we're in graduate school mode. Everywhere you go, somebody's tucked into a corner, flipping through flashcards. People are making plans around studying, which is something that doesn't typically happen. Some people are married, some people aren't married, so everybody's trying to figure out exactly how to get in the flow of things and figure it out and see what best works for them. It's all about time management, I've found.
I think so
thus
too.
far. So as long as you can give yourself a nice kind of scheduled regiment, everybody's kind of good going forward. Do you have anything else to say on that?
That's one of the things I think we're going to be experiencing throughout is making sure we make some time for school every day, but when the time comes, we gotta get ready
Every day.
for school first. But it's been good. I think our class has done a good job of mixing in some social time too. So
Yeah. For example, a lot of our class is playing intramural softball this semester. We have 2 teams, so everybody's kind of jumping into the mix with that, getting to know each other better as a class, and also kind of going out and hanging out outside of school together too.
it's been good so far.
Yeah. A couple of updates. Michigan did win yesterday. Today is Sunday. I didn't timestamp this. It was an ugly win, but I'll take an ugly win over a loss any day.
Yeah, Mizzou lost to Purdue 35-3. So
Yeah, Purdue actually looks pretty good, and they play Michigan next week. I'm a little bit scared about that. So Mizzou's not very good, so it's not very.
Yeah, not good. All right, so now we go back to school stuff. All right. So our first week, we really got into the skeletal and a little bit of the musculo part of the the back and then the upper limbs. Now we're really diving deep. We got into the neuromuscular aspect of it and the arteries this week as we prepare for our first practical and test following this week of practicals in our other courses. So day 1 this week, in our lecture class, we went through the arteries. So we began up near the neck, going into the axillary region. So we went subclavian and axillary arteries. Then we talked briefly about the triangular space, the quadrangular space, and some of the anastomoses in the arm there. In lab, we went through the forelimb muscles. So we got into the brachium, antebrachium, then our hands. So that was something a little more in depth that we didn't get to do in undergrad. We really started looking at all the muscular components to the hand. I know we briefly touched on it in undergrad, so that was a part that is different, I would say, going into the grad. We got to know every little detail instead of just the big muscles. So
Lots of details.
A lot of details. So day 2, back in lecture, we went through the brachial plexus. I think this has been the most challenging part of the anatomy portion in our program so far. Everybody's been drawing the brachial plexus nonstop, as well as the arterial system throughout the upper part of our bodies. So lab was the same. We went to the forelimb vessels and the nerves. So we've been trying to apply what we've been learning in lecture into the lab, trying to see that plexus. It's definitely a lot different than on paper when everything's going all over the place. Got a bunch of, looks like spaghetti strings just going all over the place. But everybody's been getting in the lab regularly, trying to put that conceptual aspect into real life. So anatomy's moving right along. 1 more week of lecture and lab, and then we are headed into our first lab practical and test.
So that'll be fun.
Yeah.
That'll be a lot of fun. All right, so rolling right along, aside from that anatomy, and I've seen it, everybody's got whiteboards, drawing that brachial plexus, trying to figure out what nerve innervates what muscle, and it just kind of gets crazy, especially when it gets to talking about the trunks and the branches and just where they go and how they jump around in the body. It's pretty crazy. So moving right along to kinesiology and biomechanics. The main focus this week in kinesiology and biomechanics was the spine. So we worked on the thoracic spine and the rib cage. So we talked about the osteokinematics and the arthrokinematics, jumping back and forth between those two terms. Again, those osteokinematics is basically how the body moves, and the arthrokinematics is how the joint moves against those different articulations. So the biggest thing that we kind of talked about this week was like thoracic mobility and thoracic motion, and how those vertebrae move together and how they articulate with each other. For the sake of room in here, we don't exactly have enough room. I wanted to do a demonstration for what the what the facet joints look like in the arthrokinematics and osteokinematics of the thoracic vertebrae. But essentially, we talked about like flexion of the spine. If this was an articular facet and this was an articular facet, if we were going to flex the spine forward, those facets would slide ventral and
superior.
Yeah, those are the same words.
Oh, yeah.
Ventral and superior. And then if they went backwards, it'd be dorsal and caudal, in the different terminology that we're trying to get familiar with. So we also talked about, that's flexion and that might be extension where you have that separation. But then we said, hey, what happens when you side bend? How does that spine actually work? Well, the side bending aspect was one facet is simply going to go superior and the other facet is going to go inferior. And then we talked about, hey, what if you actually throw in some rotation there? So then we talked about the gapping of the different sides of the facets. So we talked about that, we talked about side bending and then rotation to the same side, and then side bending with rotation to the opposite side, which would be a non-coupled motion, and how you get that gapping in the facets. So that was a large conversational piece this week. We talked about those different things. We talked a little bit about the cervical spine too, but more or less we kind of stayed true to the thoracic spine. Going forward, we talked a little bit about the disc, not too much in depth of how the disc moves and how it creates that cushion in between each vertebrae, the intervertebral space. And then in lab this week, we got to get into that cervical vertebrae, so we got to identify the C7 in our partners, and then we got to walk all the way down the thoracic spine into the lumbar spine. And a lot of people, it was eye-opening for what they were able to feel and what they weren't able to feel. Especially if, like for example, Josh, he was working on a partner who was a little bit bigger body than somebody else, and I remember him talking to me about, I couldn't feel anything in the thoracic vertebrae. I couldn't feel the spinous processes of any of that, and I think it's a learning curve for everybody whose hands. We have a couple of athletic trainers in our class, and they're just like they can pretty much identify anything. They've been through a lot of this stuff before. And then just working with the different people, some of the thinner people in our class, their spinous processes are like dinosaur spikes out their back, and then other people who are more muscular might have muscular coverage over some of those different areas. Their paraspinal is really kind of sinking those spinous processes deeper, and different things with that. We also talked about, a little bit less in depth, but definitely not to be forgotten, the ribs and how they actually roll with the spinal cage. With the vertebrae, how the spinal cage actually kind of rolls and recedes, and then how you can get some of the different osteo and arthrokinematics of those ribs too, which is a little bit more in depth, and it's kind of interesting how everything can kind of move in different directions based on how we're moving as a person.
Definitely makes it more complicated though.
Yeah.
Well, it's a lot of concept because we can't see it necessarily in class, so we're trying to talk it through in our minds, honestly, just in our imagination, seeing or imagining what it would be doing. You can only do so much with just two-dimensional pictures, so I think that's been challenging for quite a few of us to make a 2D thing into a 3D in our own minds.
Yeah, and I know for me, since I conceptualize everything in sports, whether it be stats or numbers or people or the different sport, I just keep thinking about like, okay, how's the spine going to be moving when a person is a right-handed hitter and they're taking that step and they're driving through their swing, and the side bend might be a little bit right, but the rotation is going left. How's that spine moving? And that kind of helps me conceptualize. So that's how I've been kind of approaching it. And obviously once I get the terminology and kind of the motion down a little bit more, I can start to apply that to more situations in life, and then just kind of think about it a little bit more directly than abstractly. So that was pretty much it for 517 this week.
511, our foundations and PT examination. We have our practicals coming up this week. So tomorrow,
First set of practicals.
First set of practicals, getting them out of the way this week. So we went into body mechanics, which body mechanics we're really looking to improve these in ourselves and in our patients. One, for ourselves so that we stay healthy, we're more efficient in our movements, and we don't want to be going on the DL whenever we're going to be treating others. So it also gives us another tool to use in treating our patients. Proper body mechanics, as defined in our Pearson text, is the use of one's body to produce motion that is safe, energy conserving, and anatomically and physiologically efficient. And that helps maintain our body balance and control. Mm-hmm. So as a practitioner, like I said, we want to stay healthy, so we're going to practice the best body mechanics, and we're going to be a good teacher and a good example for our students or our patients with that. And then on the day of the lab itself, we actually went through several different lifts. A few are familiar to others, a deep squat lift or a power lift. One that I had never even thought of was the golfer's lift, which is where you stand on one leg, kind of a straight leg, and you brace yourself on a table to reach down on the floor for like a small object instead of a bigger one. So that's one I actually used this week in just my regular everyday activities. Didn't even think about it, but somebody pointed out to me, hey, you just use the golfer's lift. So
I actually went golfing and didn't ace any of them, but put a couple in the cup and picked it up just like we talked about. I was like, I'm actually doing the golfer's lift right now.
Yeah, so those body mechanic lifts, easily implemented into your everyday, but you don't necessarily think about it whenever you're doing it. So the plan is to get so efficient at it that it becomes second nature.
Mm-hmm. Mm-hmm. Yeah, so we also talked a little bit about the systems review and cognitive screen portion of the physical therapy realm. And we got into a little bit of talking about the person as a whole, person as a whole, person as a whole. You can't just look at the person for their injury. So if they walk in the clinic and they have a shoulder injury, you can't just be like, all right, I'm going to treat this shoulder injury. No, you have to treat this person. You have to get to know them a little bit, and you got to figure out what their history is and go through the entire systems review. And the 5 parts of the system review include the cardiopulmonary, integumentary, the musculoskeletal, the neuromuscular, and then cognition and communication. And really, when you think about a physical therapist, it's rare to think about cognition as being part of that system review. We just talk about how good is their heart, what does their skin look like, what are their muscles, how do they function muscular, and do they have any kind of lapses between the brain and the muscle that might come up. And well, we have to talk about the cognition too. So we went forward with that. We talked a little bit about so for example with the cognition, just orientation, like asking the person, obviously if somebody's completely functioning and in a normal sense, you're not going to ask them, what day is it today? Do you know what time it is? Yeah. Because that might be a little bit embarrassing for yourself and for the person. So really it's only if you might suspect anything. And there's a general questionnaire that we went over called the SLUMS that is like a test that's issued to everybody, in which you literally go through a real easy test, maybe not so easy, but you just like draw a clock and say, hey, point the hands to 10 minutes to 10 o'clock, and then see how they respond to those questions and then grade it out accordingly. So we talked a little bit about that. And then obviously you still have to treat the injury, so you have to look at the person, you look at the injury, whatever they're referred for, or if they aren't referred for, what can you refer to someone else and say, is this shoulder have any kind of edema or swelling? Does it have any kind of structural damage? Does it look like that person might have any issues with their heart rate, respiratory rate? Are they changing their respiration because of the injury? Are they hunching? Are they slumping? Are they standing different? So you kind of just have to assess everything and not just one or the other. And that comes down to learning preferences and how the patient responds to you, and also how you respond to the patient.
That rounds it out for what we've done in lecture and lab for our foundations class, like we said, we got our first practical tomorrow. More of the video and picture portion, and then
some posture stuff.
Yeah, and then the actual applying some of the parts of the initial exam where we do some blood pressure and some pulse and a couple of critiquing posture, I guess, the body system.
Yeah. And don't mind my doorbell. That was just that was my wife coming up the driveway.
It's pretty.
Forgot to unplug that. Sorry.
All right, so we're gonna go move on to one of our classes that we have one time a week. It's actually the Intro to Evidence-Based Practice in BT, not to be overlooked because within our profession, as we become direct access practitioners, it's becoming more and more important every day that we are looking to become the best practitioner through research, always making sure that we're learning ourselves. So we have requirements to continue our education once we get our certification. However, some practitioners aren't doing this on the regular. So yeah. We're really awkward, man. I love it. I love it so much. All right, so the key is that we're reading scientific-based journals all the time within our profession, always looking to, kind of get the leading edge. Not everything's going to be 100% right all the time, but we're always looking for the best for our clients. And whenever there comes a new study that is about something that we may have been doing for 20 years. People in the profession have been doing for 20 years, but we realize, hey, this wasn't the best. Sometimes we have to be able to shed what we're comfortable with for something that is a little more uncomfortable, but better for ourselves and for our patients. So I think that was a big key this week from that.
Yeah, I would say one of the worst phrases that exist in our language is, well, this is how we've always done it. Yeah. Because as anybody knows, in health and human movement, science is always progressing forward. It's always changing. What we were doing 20 years ago, 10 years ago, 5 years ago might not always be right. It might have worked at the time, but the fact is that we're always evolving and we're always moving forward with what we might know and what we might want to know about how everything works. So just another point that I wanted to make about evidence-based practice is kind of like the three-headed triangle of evidence-based practice that we learned this week, which all attribute to our clinical decision making. So not only do we have the clinical judgment coming from the clinician, so the physical therapist in this case, based off of our knowledge and our prior experience, and Josh and I don't have much. I only have my prior experience working with my athletes. So there's definitely uncertainty there, but everybody's going to be at a different level of knowledge and experience. Also, the second head is going to be the research and evidence. So what do we know to be true based off of the things that we've researched, based off of the things that we've read, and the things that we use to drive our clinical judgment. And the most important part of the triangle, the third part, is going to be the patient value. So what does the patient value? What is their environment? What kind of goals do they have? What kind of characteristics do they possess? Which is probably the most important part, because if you as a clinician and a physical therapist, you can't look at a patient and connect with them at some level, or be able to talk to them or get them to be compliant with the things that you want to do, or get them to buy in to the things that you want to do, then you might as well not even be treating them. You might as well walk out the door. It's a lost cause. You could be the smartest clinician in the world and you do all kinds of research driving the evidence forward, but if you can't connect with the patient's values, then it's almost worthless. So that's a really important aspect of that triangle, and you kind of need all three to drive your clinical decision making forward. So that wraps up our intro to evidence-based practice. Going forward into clinical science, we're finally starting to pick it up a little bit in this class. We left off last week. We talked a little bit about, we're getting into the introduction to pathology and some different modes of that aspect. But we started talking about clinical models of health application, some of the prevalence and incidence of different things. So like the difference between prevalence and incidence would be, the prevalence would be this community has this amount of smokers, and that would be prevalence. If you can put a number on it, like this community, the smoking rate increased X amount or X percent over 3 months, that would be incidence. So we talked about the breakdown between those two things, and then we went into a couple of different areas, or a couple of different models. We talked about breast cancer, we talked about diabetes, we talked about obesity, we talked about the prevalence and incidence of all those things, and then how they can vary between client populations. So, you know, depending on the sex and the gender, anatomic, physiologic, genetic differences, and how they kind of expose themselves to the community. We also talked about physical activity and pathology, how basically physical activity aids everything, almost everything. So I mean, you know, it increases muscle density, increases bone density, you know, it can help decrease your blood pressure, your heart rate, all those different things. It improves immune function. So basically, it's not a cure of the world. Obviously, diet and exercise are pretty important, but physical activity is definitely a driving factor behind a healthier individual.
For sure.
We also talked about, so like I said, risk factors and complications of obesity, the prevalence in America, and then we went over these elaborate obesity trends in America, in which basically in the 1990 to 2000 to 2010 until now, it's just been a sweeping rate of increase. And I think today the overall BMI, it's like 33%.
It's high.
Or something like that.
And it's ever increasing, and that's a problem.
Yeah, which is insane. And obviously, in our population, it's hard to be like, oh, I'm fine and he's fine, but there's a lot of people that aren't fine. So we talked a little bit about that and how the trend continues to climb and what we need to do. And actually our professor brought this up this week. He said, so many healthcare professionals, they see it every day with their clients and they don't address it. And he said, it's kind of like the elephant in the room that nobody wants to address. But if you have a patient who's clearly overweight and it's affecting, for example, they come in and they have a knee or an ankle injury, well, there's a good chance that part of that knee or ankle injury is due to the fact that they might be overweight or obese. And he said, whether you're good at addressing it and you have a lot of grace in doing so, or if you just kind of bring it up bluntly, it's more important to bring it up than just to leave it be, because the issue needs to be resolved at some point. And he also talked about in the documentation for, I think, Medicare, it's actually legal, a legal standard. You have to bring it up. You have to talk to your patients about that kind of stuff. And we also touched on domestic violence, and the same thing. It's one of those things where if you see a person who you might suspect is in need of some kind of help because of domestic violence, it's kind of your legal responsibility to give them options and bring that up to them. So that was what we kind of covered in the first day, and then the second day we jumped into more, I was going to say easier topics to talk about, but not really easier topics to talk about. So now we kind of broke it down and we talked about psychosocial stuff. So we talked a little bit about spiritual impact on health and how some religions may or may not want to be treated based on their religion. You have to be respectful to that person regardless of your own religion. You can't put your bias into your work when it comes to the religion. I guess the greatest thing to think about would be like if I'm a Christian therapist and a Muslim, for example, comes into my therapy clinic, I can't refuse them treatment, or I can't treat them any differently than I would any other person. I have to respect their values and their beliefs. So we talked about spiritual impact, and then we went into psychologic conditions. So we talked a little bit about substance abuse, smoking tobacco, and drinking alcohol. We all know those things are bad. We've been pounded over the entire tenure of our exercise science careers, and kind of just the last 10, 15, 20 years, it's been a sweeping thing, like smoking's bad, all right?
Good thing is, though, that smoking is going down. That's the good news. It's the obese that we got to get on the same track. I think that may be a little more tough of a obstacle to overcome, but there are some positives in our health industry that are happening for us with the decrease in smoking. That's definitely a positive for that individual and those around them, I would say.
Yeah, and smoking is one of those things too that there's a large percent of deaths in America, and to be specific, 443,000 deaths a year due to some variation of implication of smoking, lung cancer, ischemic heart disease, COPD, other cancers, stroke. Those are all attributed to smoking, and those are 100% preventable. 100% preventable. So we talked about how important smoking can be for our healthcare, and I mean, it's again not the fix all be all, but we let me just throw some numbers out here that we talked about in class. After 20 minutes of smoking a cigarette, your vital signs return to normal. After 8 hours, your blood gas is normalized, and so on and so forth. 10 years, your lung mortality risk is equal to that of a non-smoker, like you never smoked if you just quit, and 10 years later. So a couple of things to ponder and think about when approaching your different clients talking about smoking or substance abuse in class. So another thing that's not exactly the easiest to discuss with a client, but very important in discussing their health and their longevity.
And one thing we said in class is it may not be an easy topic as a health professional to bring up, but it's even harder for a family member to bring up. So we can be that bridge to get the patient onto the right track for that person's sake and for their family member's sake.
Yeah, definitely.
Our last topic or last class of the week, I'll be wrapping this up. It's called our professional topics class, and we really dove into our ethics in PT. We just submitted, or will be submitting, our first paper, which is on the ethics of health professionals. We watched a play movie called Wit, where a patient with ovarian cancer was being kind of mistreated by some of the professionals, kind of forgotten, whereas one of the nurses was really good at the bedside manner, being there for her, being a friend in the industry instead of treated like a subject. So that was a huge eye-opener for me, because whenever I think about the health industry, I think of people like I and Zach, where we are wanting to help people. We want to be there for them and be there as a companion at times when people are going through hard things. So that was, I like that assignment because it showed a side that I never really think about, or I don't want to think about maybe. So in our lectures this week, we dove into, like I said, the ethics. And a lot of people get confusion in morality versus ethics. So I'm just going to read a couple definitions from our class. So morality involves relationships and how people live in harmony, whereas ethics is more systematic. It's a systematic reflection and analysis of morality, especially when there's a conflict. So with the APTA, we are bound to a code of ethics that we're supposed to practice by and live by with our patients. And those will help us to handle difficult situations, be it a client come in a difficult situation, or tackle a billing issue or anything along those lines. So we're really getting into the nuts and bolts of how are we going to practice, not the technical skills, but maybe more of the finesse, like how are we going to interact with our clients every day, how are we going to work with our bosses, our owners of our clinics. So how are we going to make those tough decisions when they arise? And then we actually got to practice this a little bit. So we had a case study in class. Everybody got the same case study, and we tackled it as a class. And there are three ethical problems to each, three ethical problems that can come up in each situation. One is distress, dilemma, and locus of authority. Well, in our case study, we all voted for all three of them at three different times based on different evidence that was brought forth. So it's never an easy issue. No issue is easy to figure out on our own. And even as a class, we had a tough time figuring out which was the best path to take. But we used our core principles and the duties to see which action was best for us as a professional and for the client. And we also had to look at maybe it can't be about us; it's got to be about the client first.
Mm-hmm.
So that was one of the key points that we took out of it was, you know, you may lose your job, but it's better for the patient or for future patients in the future. So definitely program is rounding us out as professionals with our technical skills, our anatomy knowledge, and all of these evidence-based practice and our ethical classes. I think it's opening some eyes of everybody that, you know, it's a tough gig, but it's a fun one and going to be pretty rewarding in the future, I think. So
And that's only week 3.
that's only week 3. Only week 3, the first semester.
First semester.
So it's pretty cool. I've had a good time so far. Looking forward to testing our knowledge in the next couple weeks of what we've been able to gather and learn from our peers and learn from our professors. So ready to tackle the weeks ahead.
We're ready to, or it's kind of nice to get that foundation laid down for our future. So, well, that's pretty much everything that we had for the entire week. All classes covered, all topics covered, maybe not in the greatest detail, but a quick summary of everything. Just kind of give you guys an idea and give us a refresher. So, again, we appreciate you stopping by and checking us out.
All right. Have a good week, guys.
Thanks.